but then I just look at it that we've been talking all about the upper limb and the neck, and we've got the shoulder for the next one, like if we're not considering to do the hip this time around. So I'm like, let's just finish with the upper limb, then we go down to the lower limb. So I think instead of the hip, it's for today, it's shoulder clinical pathway in primary care. So can you all hear me? Can I just get a thumbs up so I will know that yes, you with me? Sorry. Hello.
We are hearing you.
Okay, thank you. Thank you. Let me just check this out of the way. Don't get this. Can you see my screen?
Yes.
Okay. No. Yes, that's it. So today, the our plan for today will be we're just going to look a bit into the anatomy of the shoulder. Yes, we all know about it, just a brief overview. And then we're also going to be looking into the rotator cuff spectrum, the stiff shoulder, and its local pathway. And then we move down to the referred or systemic causes, and then we're just going to briefly treat one case study. So just a bit about the shoulder, just a recap, we've got the glenohumeral joint, which is the main mobility joint in the shoulder. When we think about the glenohumeral joint, then as far as pathology is concerned, we like as physios, we're thinking towards like stiffness, osteoarthritis, instability, and any capsular restriction and loss of active pass or a passive range of movement. And with the rotator cuff and the biceps tendon, which are the dynamic stability and the humeral head control, basically are controlled by this. Pain, we think about when we're thinking about pathology in this aspect, we're thinking about pain, we're thinking about weakness, which may be in the case of tendinopathy, it might come as a case of tear, it might be pain inhibition or bicep related anterior pain. And then we've also got the acromioclavicular joint. Don't mind this schematic clinical map. So it's just to like have an overview here. Yeah, so it's not really a nice one. Just manage it. So top of the shoulder pain, when we're talking about the acromioclavicular joint and the sternoclavicular joint, crossbody pain or direct trauma, then we should expect pain in those regions. Clavicular, sternoclavicular joint positioning and shoulder girdle pain. Then we look into the scapulothoracic articulation as well. With that, scapula is the moving platform for elevation. So if there is any altered control, this may contribute to subacromial pain and cough problem and also instability or stiffness in the shoulder. Another thing to look into, just a bit of review, is the scapulohumeral rhythm. So with any arm elevation, there is need for like a coordinated movement, coordinated glenohumeral motion, and the scapular upward rotation. So if there is anything that affect this rhythm in case of the muscles, the scapulohumeral control, then that will also can also leads to some changes that might affect the tendons and subsequently lead to pain. So all these are things that we need to look into when we are looking at a shoulder pain. If the dysfunction is coming from the scapulohumeral rhythm, once we improve that, then every other thing hopefully will fall into place. And then sometimes, yeah, cervical or thoracic link shoulder pain may be local or referred. So it's definitely advisable to screen for the neck, screen for thoracic spine and neurology, vascular and systemic causes. Of course, we've discussed the neck the last time, so I think that will make this one much easier and quite simple. So the message is not to assess the shoulder as an isolated joint when we are deciding if it decide whether the dominant pattern is local. So if we've got a shoulder pain, we have to know if it is due as a result of issues, the dominant pattern is local shoulder structure, or is it due to the scapular or kinetic chain contributing to the symptom, or is it a cervical or neurological referral, or sometimes even a systematic or referred cause of the pain? So just move into classifying shoulder pain. So when we are classifying shoulder pain in primary care, we see a patient, let's say, that present to us with shoulder pain. The first thing is to decide what is the pattern. Is it locally from the shoulder? Like, does it have to do with the rotator cuff related pain? Is it a frozen shoulder, typical glenohumeral osteoarthritis, acromioclavicular joint pain, or instability? Or we think about cervical neurological referral. Is it coming from the neck? Is it a radiculopathy type of pain that is mimicking shoulder pain? Is it myelopathy reminder, like anything that has to do with myelopathy or some other peripheral nerve overlap? Again, looking into systemic or inflammatory causes, as in the case of polymyalgia rheumatica or giant cell arthritis, other inflammatory arthritis, infection, and malignancy, or is it complete non-MSK referred pain? Maybe a referred pain from the cardiac, or apical, like in the case of the pancreas tumor, or is it a referral from the respiratory system or other visceral referrals? So the key thing for FCP here is that we should not start with the diagnosis. Let's say we see a patient, we just shouldn't conclude, oh, it's so and so. We should start by deciding whether the presentation is local, like referred systemic neurological or anything urgent that we think would be doing more good. So when we take the rotator cuff spectrum, it's an umbrella of term covering the cuff and the subacromial presentation. So usually you see patients and then you document a rotator cuff related pain. Rotator cuff related pain is a spectrum. So which do you mean? Is it an impingement? Is it a tendinopathy? Is it you thinking towards partial thickness tear, full thickness tear, or are you thinking of a cuff arthropathy or a massive cuff tear? So it's a spectrum. I think it's a very good thing for us to always document, or like to be more open, or to give more, share more light on what type of rotator cuff related pain we are thinking the patient have, like, so that will make someone else know that this is what we are dealing with, and that is how to continue with the treatment, obviously. So in the presentation for rotator cuff related pain, we've got it can either be a subacromial pain in the form of impingement. Typically, you will see pain with elevation, pain with reaching out for something, lifting, or any overhead activity. And when we're talking about tendinopathy, we're thinking, sorry, I'm not in the presentation mode, sorry. So when we're thinking about tendinopathy, we typically see the pain is more like gradual with load-related shoulder pain. And in the case of partial thickness here, the pain with some weakness, function can also be partly preserved, but then still there will be pain. Whereas in the case of full thickness here, there will be more marked weakness or complete loss of function. Especially, we should think about this if there is a trauma involved. And of course, a massive cuff tear or cuff arthropathy, this we can see significant weakness, reduced active elevation, and chronic functional loss. So, relating to the cuff spectrum clinical decision, is this routine rotator cuff related subacromial pains, is it suitable for conservative care? Is the pain inhibited? Is it a pain inhibited weakness, or is it a suspected structural tear needing escalation? So this is where the clinical decision comes in. If it's a pure rotator cuff related pain, then which is it? Is it the one that we can manage conservatively? Then that will carry on with like exercises, activity modification, obviously sometimes medication, sometimes injection in the form of steroid. Or is there any weakness? And if there is weakness, is the weakness as a result of the pain, or is the weakness as a result of something more serious than the pain, like in the case of tear? So in that case, then the management plan will change depending on that. So the basic teaching here is we shouldn't Roshetakov presentation sit on a spectrum, yeah. The history, the trauma pattern, functional loss, and objective weakness determine the urgency. I'm all talking like as per FCP. So definitely in FCP, what we're looking at is red flag. So is it something that we can treat as MSK? If not, then what next? So rotator cuff related shoulder pain, just a continuation. The typical pattern and the clinical task. I think I've said this already. Typical pattern, we get pain anterolateral aspect of the shoulder or around the deltoid region. Pain with reaching out for something, lifting. Patient might report pain with dressing or any overhead activity. They might also describe pain when they're like the shoulder is being more painful when they are lying on the side, and even sometimes when they are lying on the unaffected side. Objectively, we can see a painful arc, and then pain with resisted abduction or external rotation, and of course active range of movement can be reduced, but once we do the passive range of movement, then we'll find out that it's relatively preserved compared to the active range. So the clinical task here as FCP is to ask, is the weakness pain limited or is it a true loss of power? And then if any of this is the case, then definitely we know what to do. Was there any trauma or sudden function loss? If there is trauma, then that we suspect something. And if it's a sudden thing, then we definitely need to look into other aspects that might be causing that sudden loss of function. Does this behave like a local shoulder pathology? Yes, that's the first thing we should look into. Is it more the pain that this patient is coming? Is it more as a result of this shoulder? Like, is it really coming from the shoulder, or do we think it's coming from somewhere else? Are there any neck, neurological, systemic, or referred features? So all these are tasks for the FCPs to look into when they've got a patient presenting with shoulder pain. So a painful arc may support rotator related pain, but it does not exclude cervical, systemic, or referred causes. So yes, we might do all our shoulder tests and then there will be pain, but the painful arc, yes, it does support the rotator cuff related, but then we should also screen for the neck. Make sure that it's not a refer like radiating pain from the neck. So pain inhibited weakness versus true weakness. So this is just like a brief just distinction like the how distinction in the weakness and in like pain inhibited weakness and true weakness, because obviously that will change the management plan, the urgency, the referral, and what next to do. So in pain inhibited weakness, patient can generate the pain, like patient can generate power briefly, but then they can stop at a certain stage because of the pain. So definitely we start thinking this is more pain inhibited like than true weakness. The strength may improve if the pain is reduced or position is modified. So for some patients, let's say if we modify the position, the pain will be more, the range of movement will be more reduced, or the strength will be more inhibited in certain in certain position. So if we oppose or if we test the strength in other positions, then we find out that yes, there is no weakness. So obviously that's more pain inhibited in some certain position. So there is no clear neurological pattern. You've screened for neuro and then everything seems to be okay. So yeah, definitely you will still think it's more pain inhibited than a true weakness. It's common in tendinopathy and subacromial pain. This is very much common in patients that come with tendinopathy, so or subacromial pain. Whereas in the true weakness, there is clear loss of power not explained by the pain alone. So it may follow a trauma, obviously, sudden overload or tendon rupture, and it may suggest that there is a full thickness, cuff tear, or neurological deficit. And it's very important for us to compare carefully with the opposite side in most cases. Because if it's in the shoulder, if we've got like left shoulder pain, whatever we do as per objective assessment, it's always advisable to do it on the other non-affected side. Preferably start checking the non-affected side. That way the patient will know what you're doing and how you're doing it and what you're looking for. So when you come to assess the affected side, it will be much easier for you in the sense that patients knows what you've done on the unaffected side. So this is what should be expected in the other side. So it will be more so that you will not even have like a more false negative result somehow. So to say, because patient is already aware of how the assessment went with the unaffected. So the key message is painful weakness is not the same as a true weakness. So the true objective weakness after trauma or sudden loss of function should raise the urgency. Um, and then yes, we look into the acute traumatic rotator cuff tear. It's when to suspect this when we've got a trauma or sudden overload. Some people from accidents, some let's say from overloading, sudden overload, like carrying heavy lift, like in heavy lifters, people that go to the gym a lot, sometimes they might just decide, okay, it's time for us to add up a big progress with the load, and then that sudden addition of load might be just too much, and then it can lead to traumatic rotator cuff tear. And when there is sudden inability to actively raise the arm, marked weakness after an injury, we should suspect a tear as well in older patient after a fall or pulling injury. Now, sometimes even in older patient without injury or without a pulling injury, like even if it's not a major pulling load or like a pulling action, sometimes degenerative changes also occur in the tendon. So yeah, we should still suspect that even if there is no trauma or if there is no any significant stress to the shoulder. So it might comes up gradually and then degenerative changes will lead to kind of tear in the tendon. Although it's all depend, it might not really be a complete tear, but yeah, some changes due to aging. Pain and weakness not improve as expected. So you've been seeing a patient and you started off maybe thinking it's a tendinopathy, and then with your management over a period of 4 6 weeks there is no any improvement, then you start to suspect more of a tear than a tendinopathy. So definitely that will change your management plan. When there is marked external rotation or abduction weakness, that's another sign. And then when there is also a positive lag sign, if assessed safely. So that's something to assess at the initial stage anyway. So what's the action of the FCP? The FCP is not to manage any do not manage as a routine impingement. If there is any traumatic rotator cuff, then we shouldn't manage as an impingement. We should follow the local urgent MSK orthopedic pathway. So this also depend on where you are. This is the situation where you start thinking if there is trauma, should you image it? What sort of image do you need? Based on your assessment, are you thinking it's more rotator cuff related, or if you're thinking it's more like a fracture, more like a glenohumeral joint pathology? Like, what do you think? So that's where the decision for what sort of imaging to use also come into play. Obviously, you document the mechanism, the functional loss, and the objective weakness, which you've found out, and then consider imaging referrals where it change the management, and of course your safety net the patient. So when we're considering the image, when we're talking about when we're obviously with rotator cuff tendon, the rotator cuff, sorry, so we that's soft tissue, so definitely it's not going to be an x-ray. So the first imaging to think of is the ultrasound. That way we are able to know what is happening to the four tendons and also the bicep tendon as well. If there is any borsal pathology as well, that can also be picked up. If there is any sign of impingement, that will also be picked up. So if there is any tear, partial or complete tear to whichever of the tendons, is it one or multiple of the tendons? Is there any issue with the bicep tendon? Definitely the gold standard imaging to use is the ultrasound. So sudden traumatic weakness is an escalation feature, not a routine rotator cuff. So whenever there is trauma, the first line of trauma with significant loss of function, like after your assessment, so the next line of management shouldn't be treatment. It should be, yes, you can treat in the sense of pain management. You can maybe liaise with your GP so they would know what sort of medication to best prescribe for patient to help with the pain. And obviously, you refer for ultrasound depending on your MSK pathway. It could be you can do that from your own primary care. It could be you need to refer that patient to the other team, the MSK team, so they can have it done from there. So yeah, or sometimes you even refer to emergency so that the patient can have it done there. So you're done with the rotator cuff. Now we move to the stiff shoulder pathway with the glenohumeral joint. Obviously, in we're thinking about the glenohumeral joint, what comes first is frozen shoulder or adhesive capsulitis, typical pattern, pain, and its progressive stiffness, often affecting external rotation early. And then we also looking into glenohumeral osteoarthritis. In the case of the aged, it's also present with stiffness in the shoulder and with crepitation and activity. This is also activity related pain. This is a pattern. And in case of post-traumatic stiffness, stiffness after a fracture or dislocation or surgery or prolonged immobilization, this could all lead to stiffness in the shoulder affecting the um, glenohumeral joint. And then sometimes the serious or systemic causes can, typical pattern will be severe pain, systemic symptom, infection, malignancy, or inflammatory pattern. This can also be like present as stiffness in the shoulder. So a stiff shoulder is not automatically a frozen shoulder for most. So for most people, once they see a stiff shoulder, it's automatically a frozen shoulder. So it's very important for us to check if there was trauma before the stiffness setting in. The age of the individual, if the individual is aged, then we start thinking towards osteoarthritic changes. And then if there is systemic futures and any other red flags, and whether their passive movement is truly restricted. So now it's not only, yes, the patient cannot move it, but as a physio, we do the movement as well, like passively do the movement. Feel if there is a good the end feel, we feel the end feel, is it a like a normal one? Is there any change in that aspect? Is there any crepitation? That will give us a feel of what is really happening. And sometimes patient might report they can't move it, maybe it's pain inhibited. So if you come to move it passively, then you find out that it's not really restricted. So yeah, we should always look into it before confirming or before like labeling it as a frozen shoulder. So clinical cues, local shoulder stiffness should have a plausible pattern. So bilateral symptoms, systemic illness, severe night pain, or rapidly progressive limitation changes the pathway. So when we have bilateral stiffness, systemic illness, that points towards another direction. Obviously not a frozen shoulder. So that definitely will change our pathway. So, frozen shoulder, adhesive caps, a global stiff shoulder pattern rather than only pain with resisted loading. The pattern, we've also mentioned that gradual onset shoulder pain stiffness, typical night pain may disturb the sleep. There might be restriction of active and passive range of movement. The capsular pattern movement commonly limited. Talking about the capsular pattern and the flexion, abduction, and external rotation. These are the three movement that is usually restricted, like usually involved when in frozen shoulder. And difficulty with dressing, reaching out overhead, washing hair or fastening bras. Sometimes patient can also report this, and it may be associated with other comorbidities like diabetes, thyroid diseases, or previous shoulder injuries. And the frozen shoulder is more likely when the shoulder is globally stiff. If passive range of movement is preserved, then we would consider the diagnosis. The message here is if pain is severe, systemic, traumatic, or atypical, then although there is stiffness, we need to screen for other causes before applying a frozen shoulder pathway, sorry. So just for this is just frozen shoulder versus glenohumeral arthritis. So if we're not thinking frozen shoulder, what other thing can lead to stiffness in the shoulder? It's glenohumeral osteoarthritis. Onset, often frozen shoulder is a gradual onset, and sometimes it is idiopathic. It's usually glenohumeral osteoarthritis. However, it's also usually gradual, but then it is age related. So older people, we see we or for older individuals, we suspect more osteoarthritis. But again, there is think literature that says anything 4 to 5. We should also suspect frozen shoulder in individuals that 45, 50, especially in women, perimenopausal and like early stage of menopause. Then pain is often painful and especially painful at night or it's often painful usually at night or early in the morning. And then glenohumeral osteoarthritis is more activity related aches, and it may also have a night pattern pain. Then the range of movement in frozen shoulder is global restriction, especially in with external rotation. Then in glenohumeral osteoarthritis, still it's restriction, but there could be the possibility of crepitation in the joint. So age pattern, often middle age, yep, for the frozen shoulder, and more common in older adults, as in the case of glenohumeral osteoarthritis. There are also other risk factors, diabetes, thyroid diseases, and previous injury in the case of frozen shoulder. Whereas in the case of glenohumeral osteoarthritis, the risk factor is age, previous trauma, and joint degeneration. And imaging. Again, this is where we look into our imaging. Patient comes in with stiff shoulder, and we are thinking, is it a frozen shoulder or is it glenohumeral osteoarthritis? So what are we going to do? What imaging should we check? Like with what imaging is the gold standard? The gold standard is the X-ray. So if it's a glenohumeral osteoarthritis, obviously changes will be seen in the glenohumeral joint and also the acromioclavicular joint. So that will also change somehow our management plan, because for some people that will show how severe the changes are. Some might need a shoulder replacement. But in the case of frozen shoulder, everything will be normal, like as in the case of the glenohumeral joint, space will be well preserved, no any osteophyte, and that will make us conclude that it's more of a frozen shoulder rather than osteoarthritis. And then that will also that will also help us with our management plan. Obviously, conservative management for some individual, and sometimes another good intervention for frozen shoulder, especially at the early stage, is injection. Injection will definitely help with the pain, and then you maximize the no pain period to carry on with your exercises and other conservative management protocols. Again, with frozen shoulders, sometimes it can be too some patient might also need uh capsular I'm trying to remember the word. Um, Capsular release. Yes, they might also need capsular release, and that will improve the stiffness in the shoulder and obviously carry on with exercises. So do not diagnose from stiffness alone. Use onset, range, pattern, age, risk factor, and red flag screen to select the pathway. So we go to the acromioclavicular pain and shoulder instability. The local shoulder pathway with important trauma threshold, we're looking at ACG pain pattern. Pain usually localized to the top of the shoulder. It may follow a direct trauma or repeated loading. Pain with cross-body adduction, like in this case of the scarf test, that will be positive. Pain with pushing, bench press activity, or lying on the side can also elicit the pain, and local tenderness over the acromioclavicular joint. So in the case of instability or dislocation pattern, can be attributed, like can be as a result of trauma. When there is a trauma, when there is a fall, we should suspect instability and dislocation in the shoulder. When there is a collision injury, or when there is like a throwing injury or a previous history of dislocation, can also prompt the us to look into, could it be another dislocation. Feeling of sleeping or apprehension, that we can always test with our apprehension test. And then dead arm being reported by the patient, or shoulder coming out of place. So visible deformity, severe pain, or inability to move after injury is suggestive of possible dislocation. Definitely, that will also change our management plan. So, shoulder red flag, practical escalation threshold. So when for like a same day emergency or urgent escalation, when we are suspecting septic shoulder, so just like we have with the lower back, we have the urgent like or same day emergency, and then we have the serious pathologies that will prompt an urgent input, and then there are other pathologies that we can treat as a routine MSK. So the same thing with the shoulder. We've got, if anything like suspected septic shoulder, then it's an urgent escalation. If there is unreduced dislocation, patient presented with shoulder pain, and then after your assessment, you find out it's more of a dislocation. Definitely, it's not a routine MSK. So the pathway will also change. When you're suspecting fracture, when you're suspecting acute traumatic cuff tear with marked weakness, when there is unexplained mass or swelling around the shoulder, when there is a previous history of cancer with progressive pain in the shoulder, then that's also another urgent thing to look into. When there is chest pain associated with the shoulder pain, breathlessness, sweating, nausea, jaw, or left arm symptoms, that's also another thing that needs to be seen, look into thoroughly. And then neurological or vascular compromise after a trauma. So for routine MSK, when there is no red flag, of course, after screening, when there is no any systemic feature, when there is no any acute traumatic loss of function, no any progressive neurological deficit, symptom fits a local shoulder pathway, then patient can be safety netted appropriately and treated as an MSK condition. So we're now going to look into pain that is not from the shoulder, but it's been like a referred pain or and the systemic shoulder pain. So the pain, the actual cause of the pain is not in the shoulder, it's from somewhere else. So when the shoulder is the site of the symptom, not the source of the pathology. Shoulder pain reported, does it behave mechanically? No. If no, could you screen for cervical referral, neck-related shoulder pain? You screen for cardiac referral, screen for polymyalgia rheumatic and giant cell, and then apical or lung or like pancreas tumors. So if the pattern does not behave like a shoulder problem, which we've all discussed earlier, Then we pause and then we screen for cervical, we screen for systemic, we screen for cardiac and respiratory or malignancy related causes. So with this, we come to one of the systemic ones, the polymyalgia rheumatica as a shoulder mimic. Polymyalgia rheumatica may look like a shoulder pain, shoulder problem, but then the pattern is usually bilateral and it's inflammatory and systemic. So what is polymyalgia rheumatica? It is an inflammatory condition that commonly affects shoulders, that it's commonly affect older individuals and causes pain and stiffness in the shoulders and also inflammation around the neck, shoulder, the hip, and the pelvic girdle. Typical symptom area. So in the typical symptom areas include shoulder girdle, the upper arm, the neck, the pelvic girdle, and the hips and the thigh. So patient present to you with like bilateral shoulder pain, might have other pain in other part of the body, like the upper part, the neck, might come with stiffness, and it doesn't really fit the local shoulder pathology. Then we start thinking towards polymyalgia. Typical clinical pattern, usually the patients are over the age of 50 and it's of bilateral and or with other joints being affected, usually reporting morning stiffness, often lasting longer than usual, degenerative changes like osteoarthritic changes, and symptom may improve as day progresses. Difficulty dressing up, washing hair, turning in bed, or raising from a chair. So anything that has to do with loading the shoulder or overhead activity, then that can be painful as well or difficult to do. But this is more bilateral presentation than unilateral. So identifying the futures, we suspect this when the age of the patient is over 50, when the patient presents with bilateral shoulder and or pelvic girdle pain, symptom lasts more than 2 weeks, and morning stiffness lasting longer than 45 minutes, and functional difficulty with overhead activity. There are some other less common features that might be there or might not be there, such as fatigue, low-grade fever, reduced appetite, weight loss, or low mood. Systemic symptoms occur in at least 40 to 50% of people with polymyalgia rheumatica. So when we're trying to screen out, it doesn't really fit in for the local shoulder pathology. Let's check with polymyalgia rheumatica. So they've got all the suspected pattern. Do they have these less common features as well? That will kind of give us more idea about what we're dealing with. Bilateral upper arm tenderness sometimes can be present, and peripheral MSK signs seen in approximately 50% of people, and this include carpal tunnel syndrome. Some of them might come with carpal tunnel syndrome or peripheral arthritis, predominantly affecting like the knees, the wrists, which is asymmetric and self-limiting. And then they might also present with swelling, pitting swelling of the hand, the wrist, the feet, and the ankles. So look also in around the extremities. Pain in both shoulders, sometimes with hip pain or pelvic girdle pain. Are they also having pitting edema in their extremities? That will further confirm your suspicion of polymyalgia rheumatica. Muscle strength is not usually impaired, but muscle pain inhibition may make testing difficult. So for this type of patient, yes, it's not true weakness, it is more due to the pain inhibition. So if symptoms are protracted, disuse dystrophy or muscle can occur, leading to muscle weakness. So assessment in FCP clinic for polymyalgia rheumatica. The aim is to recognize the inflammatory pattern and exclude urgent mimics. So the aim in the first, as a first contact physio, it's not for you to treat that polymyalgia, it's for you to identify the pattern. And then you're able to signpost the patient to the right person to help. Obviously it's it's systemic, so definitely it's autoimmune, so it has to do like the GP it's a multidisciplinary intervention. So definitely it's not going to be physio managing it completely. So the GP will have to come in, the pharmacology. Subjective assessment will include the onset, the duration, and the progression. Bilateral shoulder and or hip girdle symptoms, you've got to all check for that. Is there any morning stiffness and stiffness after resting? Is there difficulty with dressing, washing hair, turning in bed, or rising from a chair, or any overhead activity? Is there fatigue, fever, appetite, weight changes, and is there any past inflammatory diseases, any malignancy, any infection or endocrine diseases, and what are the current medicine, including statins? Because sometimes long-term use of statin can also induce muscle ache, like can mimic symptom of polymyalgia rheumatica, but then it's not actually polymyalgia. Then objectively, you need to assess for active and passive shoulder range of movement. Of course, you also would not only consider the shoulders, you've also consider assessing the hip range and function, if indicated. If at all patient mention anything relating to the hip, you also need to look with the peripheral joint swelling. Are they hot, red, or swollen joints? And you also need to look into neurological involvement, signs if there is any nerve involvement, and then features that do not fit for polymyalgia rheumatica. So you've searched for all features that fit in for polymyalgia rheumatica. What if it is not polymyalgia rheumatica? Then you search for other symptoms. That yes, I'm thinking it's polymyalgia rheumatica. What if it is not polymyalgia rheumatica? Could it be something else? Then you search for features that do not really fit in for polymyalgia rheumatica. So always screen for giant cell arthritis. So with polymyalgia rheumatica, it's very important that if we're suspecting patient with that, we also screen for the giant cell arthritis. PMR, type shoulder pain plus cranial or visual symptom is a red flag presentation, which is an urgent referral. So GCA is a serious inflammatory vasculitis affecting the medium and large arteries, and it can involve the temporal arteries, and it can cause irreversible visual loss if missed. So for all patients that you think in polymyalgia rheumatica or you confirm polymyalgia rheumatica, you definitely need to also screen out for giant cell arthritis, because if at all they've got that, then that can also cause irreversible visual loss if not acted upon on time. So for giant cell arthritis, we need to ask specifically about if there is like headache, new headache, especially around the temporal region, if there is any scalp tenderness or if there is pain when like brushing their hair. Do they have any pain around the jaw, like any claudication or jaw claudication or tongue claudication, any blood vision, double vision or visual loss, anything at all that has to do with visual impairment, any eye pain and temporal artery tenderness, and if they've got fever, malaria, weight loss, or reduced appetite. This is very important, so we don't miss out the giant cell arthritis, and so we don't risk so patient is not at risk of losing the visual function. If giant cell arthritis symptoms are present, this is not a routine MSK care. So we follow the same day urgent medical or local pathway, and also make sure to document the red flags um, and clearly safety net the patient that this is what we think, this is what we've seen, and we're suspecting GCA. So definitely it's not for physios alone. The investigation and the referral consideration. So for blood tests support the picture for polymyalgia, they do not replace the clinical reasoning. Yes, the clinical pattern fits, but there are also some other things that can be like that can support our findings clinically. So the baseline blood commonly considered are the ECR, the CRP, the full blood count, urea and electrolyte, LFT. We also do the bone profile and the calcium. the TFTs and the CK rheumatoid factor and the CCP if inflammatory arthritis somehow possible, because somehow you might also be thinking towards inflammatory arthritis causing the pain rather than polymyalgia. And you also want to also look into the blood glucose, especially if steroid, because with polymyalgia rheumatica, definitely the management is pharmacological management, steroid. So you're going to place patient on steroids. So you definitely need to know the baseline for their blood glucose, especially because they are going to be on steroid for a long time. It's not like a 1 week, 2 weeks, and then they are off it. It's going to be on a long time. I think more than, I'm not sure, can't really remember, but it's going to be for a long time. And then it's something that they don't just come off it again. They have to wean them out of it. So basically, all that stuff is pharmacology and with the GPs. So why the investigation? The investigation will support inflammatory pattern and it will also exclude mimics such as infection, such as malignancy, such as thyroid diseases, inflammatory arthritis, or myopathy. And it's also provide a baseline safety before steroid treatment, yeah. And also it will also help to monitor their response and if they've got a relapse. So if the sick medical or specialist advice when the age of the patient is 50 and it's atypical feature, and you see normal or unusual inflammatory markers, poor corticosteroid response and recurrent relapse or prolonged steroid need, and suspected GC giant cell arthritis or diagnostic uncertainty or significant comorbidity. So all these are like things that FCP needs to look into when they're dealing with individual that they're thinking polymyalgia rheumatica. So the FCP role is to recognize the inflammatory shoulder pattern, screen for the giant cell and serious mimics, and communicate clearly with the GP or the medical team, and also safety net the individual for visual, cranial, or systemic deterioration. So it might be I've seen the patient and I've done all this, and someone will say she didn't do really anything. Like, what did she really do? So had it been your role as the FCP is to spot if there is any red flag, which you've done. So I think you've done your work. So it does not really mean until you do that hands-on physio. This is first contact physio. You're there to screen, make sure that you're not missing the red flag, and you escalate up appropriately. So another serious pathology for the shoulder is septic arthritis. With septic arthritis, we're talking about a hot, painful joint. Patient is systemically unwell until proven otherwise. This should be considered as a septic arthritis. Why it matters is that infection, if it is uncommon, septic arthritis is infection within a joint. It is uncommon, but then if there is any delay in treatment, this can lead to the joint damage, and sepsis can lead to sepsis and also can lead to significant loss of function. So suspect if shoulder pain present with sudden severe pain, usually developing quickly when the joint is red, hot, or swollen, when there is severe pain with small shoulder movement, as little as a movement, the patient is shouting pain. You suspect septic arthritis. When there is marked restriction of active and passive range of movement, again, you should also suspect septic arthritis when patient present with fever, chill, sweat, or systemically unwell. And of course, when there is recent infection, any wound injection, surgery, or immunosuppression, definitely you think septic arthritis. Again, do not continue shoulder special tests. Don't do any provocative tests because that will obviously make things worse for the patient. And then as an FCP, you need to escalate urgently and it's the same day. You communicate possible septic arthritis, you document the red flag, and you also still safety net the patient. So with this, we move to another serious shoulder mimic, the Pancreas tumor, the apical lung pathology. It's a progressive shoulder or scapular pain, which can occasionally be a long or apex presentation. So, Pancreas tumor is a superior sulcus tumor at the apex of the lung, and it may present with shoulder pain, scapular pain, neck or arm pain, and through local involvement of the brachial plexus, the ribs, the vertebra, or sympathetic chain. What are the red flags to spot on? There is severe, persistent, progressive, or unremitting shoulder and scapular pain, and there is which is poorly explained by shoulder movement or loading. Like patient is having pain, but then he cannot really explain why is the pain coming. Like why is he having pain? Arm pain, paresthesia, hand weakness, or hand muscle wasting can also be present. Patient might present with symptoms of cough, breathlessness, and hemoptysis, weight loss, or even in a patient with smoking history, we should suspect apical or pancreas tumor. So when they come in with shoulder pain, so we definitely need to screen out for that as well. Then sometimes they might present with Horner syndrome, like the dropping of the eyelid, the small pupil or reduced sweating on one side of the face. Still, we are not to manage as a routine MSK shoulder pain. The best thing is to escalate. The best and right thing to do as FCP is to escalate through the medical team, suspected cancer or the suspected cancer pathway, and then document any neurological, respiratory, and systemic red flags, and also safety net the patient. So with this, we move to the cardiac referred shoulder pain. Cardiac pain may be felt in the shoulder, the arm, the neck, the jaw, the back, the upper abdomen, or the chest, as we all know. It matters because cardiac referral may present as a vague shoulder or arm discomfort rather than a classic chest pain. So the key clue is systemic or exertional behavior rather than mechanical reproduction. So mechanically, you move the shoulder, you did all your shoulder tests, and then the patient is not reporting the pain. But with any exertional behavior, patient will report pain in the shoulder. So we suspect cardio referral when pain is triggered by walking, stairs, exertion, stress, emotion, or cold. When it is associated with chest tightness, heaviness, with pressure, squeezing, or indigestion like discomfort, and then associated sometimes with breathlessness, with sweating, nausea, dizziness, paleness, or feeling faint, and it is by rest or reduced activity. Otherwise, nothing will make it come down. So, not clearly reproduced by shoulder movement, palpation, resisted testing, or cervical loading. So, present with cardiovascular risk factors. Of course, we need to check if we've got a patient with shoulder pain that is not triggered by all of the shoulder assessment. Resistance testing is okay. Cervical test is normal. Every other thing is okay. But then the patient says he's still got pain with shoulder. Then we subjectively look into when do you get the pain more? What do you do that causes the pain? Then that way we'll be able to get the pattern, like what causes the type of, because obviously objectively we're not having anything. So we need to look into the subjective assessment. That is where we can, unless of course if we subject the patient to a bit of a bit of stress just within that clinical time, which of course is not possible. So we definitely need to look into the subjective. If the patient is saying, once I just walk for like 30 minutes, I start to get pain in my shoulder and it doesn't get better until I've rested, and that patient, we look into their profile, they have the cardiovascular risk factors, obesity, hypertension, diabetes, like all other cardiovascular risk factors. Then we should think the shoulder pain, it's not as a result of the local shoulder like structure, it's more a referred pain from the from the cardiovascular system. So stop routine MSK assessment if cardiac features are present, and you also follow the urgent emergency pathway, depending on the presentation, of course, and document exertional pattern and safety net clearly as well. So we're looking into dislocation, fracture, and neurovascular compromise. So after a trauma, it is advisable not to start with special tests. First, we need to exclude urgent injuries. So we should suspect serious traumatic pathology whenever we are presented with a patient that has with a fall, collusion, seizure, electric shock, or high force injury. So we shouldn't just go into moving the patient, doing all our tests that might make it worse. So we should suspect a serious traumatic pathology. When there is shoulder deformity, when there is abnormal shape or visible asymmetry in the shoulder, we should also suspect serious pathology if there is severe pain with inability to move the arm, when there is marked bruising, swelling, or bony tenderness, or when there is loss of rotation after trauma, or when there is sudden weakness after injury, or when there is numbness, tingling sensation, or altered sensation, or reduced hand function, or when there's cold, pale limb, or reduced circulation sign. So the action for the FCP is not to attempt to reduce a suspected dislocation and not to continue any routine testing if fracture or dislocation is suspected, and also to check and document neurovascular status. The sensation, the movement, the color, the temperature, and the circulation all should be well documented, and then we escalate immediately to the emergency or the urgent pathway. Another thing to do is safety net for worsening pain, numbness, weakness, color, and changes or inability to use the safety net the patient. So the key message here is a painful, deformed, or neurologically altered shoulder after trauma is not a routine shoulder pain. It's more of an urgent pathway protocol. So with this, I think we've come to the end of the shoulder pathway for today, and we have this case-based discussion. I don't know if the coordinator is going to unmute, and then we get to hear what the audience have to say about this. So we've got a 74-year-old retired soldier that present with bilateral shoulder ache and neck stiffness. There is no clear mechanism of injury. Over the last 24 hours, he has struggled to get dressed and he cannot do his usual upper body workout in the gym. What do you want to know? Is there anything you would want to know regarding this patient when he present to you in the clinic? Before examining the patient, what information will change your pathway or urgency? What do you need to know? Hello, Dr. Idris? I'm not sure. Dr. Idris? Is there anyone who wants to attempt this?
Yes. Good evening.
Good evening, sir.
Yes. I think we need to have information on whether there is previous history of trauma or fall, because this guy is a soldier.
Yes.
You know how to, so you need to know all these previous information, because that will give you a clue.
Okay.
Yes. For your chance, examine that patient.
Okay. What other thing would you want to know? Aside from history of trauma, any other thing, sir?
I think that's what you need to know. Previous history of trauma. That will give you everything.
There is a bit of information on trauma. I think just it's not that elaborate. It says there is no clear mechanism of injury. So it means in a way that he's not fallen recently or like any new
No
in.
problem. Let me do that. Let me unmute.
Okay. What do you want to know? The thing is, one thing I realize is, to be honest, practicing back in Nigeria, I don't get to see lots of people with shoulder pain. Most shoulder pain is I saw back then was people with stroke are coming in with shoulder pain. But here we see a lot of shoulder pain. That's just one thing I realized, like comparing to my practice back home anyway, regarding shoulder. 74-year-old retired soldier present with bilateral shoulder aches and neck stiffness. There is no clear mechanism of injury. Over the last 24 hours, he has struggled to get dressed and cannot do his usual upper body workouts in the gym. What do you want to know? Anyone? Please, let's make the session a bit interactive, please. It can be anything. It can be anything. It can be something I can also miss, someone else is not even thinking about. So I think it will be best if we, even if it is in the chat, let's see, can I just,
Hello.
yes, sir.
Yes, thank you very much for the wonderful lecture. So for this particular patient, we may want to actually screen out for other joints of the part of the body. So we want to know whether the pain is actually also being felt in places like the pelvis, like the hip, and since it's a bilateral presentation at the shoulders, so that will make us not to start to think of frozen shoulder or to start to think of osteoarthritis of the shoulder because of the bilateral presentation. So we
Yeah,
want to actually also look for other systemic involvement based
yes,
on the presentation of the patient. We want to ask other questions or to actually request for other investigations that can point us to actually think of other systemic involvement. We also want to ask him whether there is any form of cardiac pathology that the patient is being treated for
yeah,
or any other systemic disease. So I think we should broaden the net beyond this shoulder alone because of this bilateral presentation that
presentation.
is presented. Thank you.
Thank you, sir. Thank you, sir. That was a nice one. So yeah, we should check if he's got pain in any other part of his body, like the hip. Any other contribution, please?
Hello, good evening, ma'am.
Good evening, sir. Thank you for your for contribution. Yes. What do you think? What do
Although
you
I
want
just
to
want to
know?
share something. I got
Something like that. Only my
almost a similar patient. Although the patient was not a soldier,
Yeah.
he's an engineer. So
Okay.
he fell down of his while sleeping from his bed.
Mm.
Even though the bed was very low, but after falling down, he sustained bilateral shoulder dislocation, and I asked him whether he's taking alcohol or any drug or steroid, but he told me that nothing. He's not taking any of such drugs.
Yeah.
So he went straight. They reduced this thing. They corrected the dislocation.
Yeah.
They put him on arm's length because they did not refer him for physiotherapy.
Mm.
It was later his wife discovered that because she's working in the hospital, she discovered that the man needs physiotherapy. So she asked him to come down for us.
So you see, for this patient, clearly there was a trauma, right? Unlike in this case, there is no clear mechanism of injury. So
Okay.
assuming this patient comes to you, what would you want to know? From subjective, we are not looking into the objective now. We are more
Yeah.
looking into the subjective. What would you want to know? If a patient comes to you, he's a retired soldier, he's 74 years, and he just complaining of pain in both shoulders and stiffness in the shoulders and neck as well. But then he report no injury, no injury. Have you fallen 2 weeks ago? No. 1 year ago, no fall, no any whiplash, like no any no any accident. And he only said over the last 24 hours, I've been having difficulty, struggling to get dressed and do my usual workouts in the gym because every evening he goes to the gym and do his workout. But then he's been struggling for the past 24 hours. When he went to the gym, he was not able to do his or overhead activities. He's just feeling not too okay with the shoulders. What would you want to know? What will you ask him subjectively? What will you ask him that will make you think, is it the shoulder or is it something else causing the pain?
I want to add something.
Yes, sir.
Um, this case is somehow complex. I think we have to ask this patient a lot of things about his sleeping pattern, as well as you see, we have to ask whether genetic information, especially family history, because you see, neck stiffness is something that doesn't just occur suddenly. It's not something that just occurs just suddenly neck stiffness. I think maybe something has been happening with him, then the symptoms just appear. We need to ask whether genetic information, family history, whether there's similar case.
So when
as well
you're
as sleeping
asking him, sorry to cut you in, when you're asking him of family history, what will you be like? How will you frame it? How will you frame the question like for him to understand so we will all get what you want to know? Like, how will you ask him? What will you ask him?
Yeah, you ask whether there are the similar case that happened in the family before, and yes, you ask whether something similar happened because we have so many genetic cases like this, rheumatoid arthritis, ankylosing. It runs in the family, so probably you may get information from the past history or family history.
Okay. Mind you, with this patient, he it's like more of a sudden
Hello, can I
presentation.
contribute?
Yes,
Please, can
please,
I
you can.
contribute?
You can.
Yeah. Good evening. Thank you very much for the wonderful presentation. Looking at his usual upper body workout in the gym, I may like think that possibly he must have overloaded the upper limb muscles, and that leads to maybe either muscle strain or ligament strain around the shoulder joint, or possibly mild muscle tear as a result of previous workout overload of muscles during a workout in the gym. Possibly may be the reason why he has this sudden a presentation of pain and functional limitation around the shoulder.
So over the
Thank
last
you.
24 hours, he has struggled to get dressed and cannot do his usual upper body workouts. But before 24 hours, he could do them.
Okay.
He could do them. So possibility of tendinopathy or tendinitis, but is it a sudden presentation? Does tendinitis happen suddenly? What would you want to know? If you're thinking towards tendinopathy or tendinitis, what will you ask him then? Any specific question you will ask him?
Yes, I think I can ask this patient whether maybe since it's over the last 24 hours he has struggled to do that. So maybe 48 hours back, has he engaged in a very strenuous
Good.
activities in the gym that resulted to
Good.
that?
Yes,
Okay.
good. So good. That's a good one. So you're thinking tendinopathy, or tendinitis. So definitely you're going to ask questions regarding that. So aside that, what other question will you ask him?
I want to add something.
Good. Thank you, Ma.
Okay, so I'm thinking in the line of the systemic ones that you've been talking about. We would like to ask if he has been experiencing maybe persistent fatigue for the last couple of days, if he has been having headaches, if he has been having maybe fever. Just asking along the line if you are thinking towards the systemic complications that could lead to that.
And if you are talking about systemic, so which of the systemic will you be thinking towards? Will you be thinking towards what in specific? Because when you're thinking like the former speaker, he was thinking more tendinitis. So his question will be more of around that area. So with you, you're thinking more systemic. Systemic, what in particular are you thinking? And what do you think is the appropriate question to ask the patient for you to know more about him? Does that make sense?
Yes, it does. But there was one particular one you mentioned that one of its indication is this bilateral shoulder aches. I'm trying to remember the name right now. That's the particular one we'll be thinking towards, and that's the one I'm thinking towards. That's all I can say for now.
Okay, so if you're thinking towards that particular one, although you can't remember the name, I'm not going to tell you, not now, I will tell you, I'll remind you. So what will you ask in regarding to that particular one? So it's polymyalgia rheumatica, yeah? I've reminded you. So
Yes,
what will you ask to screen for polymyalgia rheumatica? What will you ask the patient? What will you want to know? Could it be polymyalgia? Let me ask further. This, that. What would you want to know? It's a nice one. Any other person?
Okay, so I also want to ask if he is having maybe pains in the pelvis and the hip, if he has any other pain or stiffness, maybe early in the morning, and like the ones I said, also like loss of appetite, unintended weight loss, weight rather.
Good.
Yes.
Good. Nice. That's a good one. Thank you. I think until we have more than enough response today, we're not going to move forward. We have at least 4 to 5 minutes to go. So yeah. someone can unmute and then let's discuss further. I just want to know, what do you want to know? That's it. I just want to also learn from you today. What do you want to know regarding this patient? Anything that I might have missed? Anything that I should think of as well? Dr. Idris, I think some people are writing in the chat. If you can help read out their response, please, then it will give us idea about what others are also thinking, so we don't miss out on their response. Dr. Idris?
Hello.
Yes, sir.
Me too, I just want to stress on this polymyalgia, this thing, rheumatica.
Yeah.
I would stress more on the pain. Is it worse in the morning, and then how long? The
Yeah.
duration of the pain and stiffness. As
Mm.
you mentioned, and you
Yeah.
go ahead and ask if there is pain in the hips or pelvis.
Yeah.
I think that will also confirm the issue of this polymyalgia rheumatica.
Yeah. So,
And then you can also ask for any cardiac symptoms,
okay,
any
like,
other like chest tightness or heaviness also.
good.
It will also help.
Good.
Thank
So, sorry, don't go, please. So, we've got a bilateral shoulder ache and neck stiffness. Aches and
you.
neck stiffness. So, we'll be thinking what might cause the aches and stiffness. One, it might be tendinitis. Yes, we will ask so and so question. Two, what other thing can cause it? Polymyalgia rheumatica, and we've asked so and so question. What other thing aside polymyalgia rheumatica and tendinitis do you think can cause aches in shoulders? Aches and stiffness in shoulder. Any other thing that will come into mind? Any other thing?
Yeah, that's the cardiac symptoms.
Aside from the
Thinking of.
cardiac symptom,
Okay,
causing
maybe
aches and
maybe
stiffness.
maybe this that one
Stiffness,
tumor you mentioned that is at the apex of the lung.
pancreas
Something like yes.
tumor.
Yes. Yes.
So if you've got a patient that you are thinking, could it be pancreas tumor? What would you want to know? If this is the patient, what do you want to know further? What will you ask?
This one. This one is
So that's the
beyond.
logic, that's where the clinical decision comes in. Because you're trying to diagnose what is happening, right?
Yes.
So you
Yes.
think of this and you think of what is not even there to think of. Does that make sense? So I'm
Yes.
thinking, oh yeah, all shoulder pain is not tendinopathy. Usually,
Yes.
typically, it's just tendinopathy, osteoarthritis, or frozen shoulder. But no,
Yes.
there are other conditions. So
Yes.
what is the patient presenting with? What other conditions can have the same pattern of presentation? So in that way, we are able to screen. If it is polymyalgia rheumatica, you've asked the patient, have you a pain in your hip? He said, no pain in my hip. Yes, there is no pain in my hips. Did you have any loss in, have you lost your appetite recently? Do you have any fever? No, I don't have fever. No, I've not lost
Mm.
appetite. Yeah.
Yes.
So you get
But
that patient, that odd ones that will come, and then yes, you will have to dig in further. So this is one. What do you
yes.
want to know?
Thank you. But my strong conviction is this for polymyalgia, this thing, rheumatica.
I am not disputing that, like I'm not saying it is not polymyalgia rheumatica, but I just want you to give us more reason for us to accept it. Do you
Yes,
get?
that
So
is why
for
I
us
said
to
I will
accept
stress
it,
more on
what
the
will you
pain.
ask the patient? What would you want to know?
I'll ask
Hey,
about
Thank you, ma.
okay. I would ask if the patient has any history of smoking. That's for this other one. that has to do with the apex of the lungs.
Yes.
Cancer of the apex. Good. I'll ask
Yeah.
then about the breathing pattern of the person. Is the
Good.
person, when the person engages in exercise, is the person restless? How long does the person walk before becoming restless? And when the person is resting, does he feel better?
Cardiac, lungs. Yes.
Those cardiovascular parameters, do they get better when the person is at rest? Or do they get, when the person is engaged in any form of activity, are they worse? Does it get worse? So I would find out from the patient, I mean.
Okay, that's a good one, Ma. Thank you. Any other thing you would want to know about this patient? Obviously, he is 74. 74, you thinking 74 years old retired soldier? Any other comorbidities? Don't you think you want to know that? Is he on any medication? Would you want to know more about that as well? I'm just giving a bit of a clue. All these are things we can ask in subjective, especially in places where we don't have access to like patient's information as a whole. Do you get, like in Nigeria, like we don't even know what sort of medication the patient is on, unless if the patient present to us with all because it's not an electronic system we are using. Obviously, we are just starting to use the electronic system. So access to all those records is not there for me to see that, okay, this patient is hypertensive, he's diabetic, and he's on so medication. Is he on statins? That's something I will also want to know. That's another thing I will ask maybe. Maybe you can also, aside, if you're thinking polymyalgia, check the hips, which is okay. Check with the extremities, any patents, edema, any swelling. Has he got any osteoarthritis anywhere in the knee, ankle? Everything okay? I don't want to carry on. I just want to hear more and more ideas. I want to hear more ideas. What would you want to know? If you're thinking polymyalgia rheumatica, and clinically the patient is telling you, I don't have pain in my hip, I don't feel fatigue, like I don't feel fever, I don't feel I've lost my appetite. As a clinician, what would you want to know? Would you want to screen to see his blood tests? Would you want to screen for something? Would you want to request for x-ray? What would you want to know? That's what I want to know. Dr. Idris, please, can you read the chat for us so we can carry on? I think a lot of people have said. Dr. Idris or someone else, please kindly help us with what is there on the chat, and then we can move forward. Hello.
Okay, someone on the chat is thinking that if the case is sudden within 24 hours,
Yes, sir.
there is not likely to be polymyalgia rheumatica. Someone is also thinking that in the case of polymyalgia rheumatica, you should request for ultrasound of the shoulder. Someone is also saying that we should ask if there is associated fever.
Yeah.
And someone is also asking that we should know the pattern of stiffness, time of the day. That does the pain come with activity like walking or at rest? Someone is also saying that we should query infection or
Good.
vascular origin.
Now we are digressing a bit. Yes, thank you.
So someone is also saying that we should know if there is pain elsewhere, like the
Good.
hip and the pelvis.
Good.
Thank you.
Thank you. Thank you, sir. So, should we move on? Yes, I think we should. So, the key question to ask, you use the question to identify whether pattern is local, whether it is inflammatory, neurological, or urgent. So, the question should not be to just confirm, like, yes, I'm thinking, if you're asking question to confirm polymyalgia rheumatica, definitely, or if you're thinking the patient has come with polymyalgia rheumatica, so all your question will be like, I don't know, all your questions will be towards that polymyalgia rheumatica. Does that make sense? You won't think out of the box. Think it might not be first you look, is it local? Your questions should start with the local shoulders. Is the pathology coming from the local, like the shoulder? If you screened out with your questions and it's not coming from the shoulder, then you go on to look into inflammatory causes, neuro causes, and other things to just fit in the pattern. Otherwise, if you are more thinking it's shoulder pain bilateral, it is definitely rotator cuff. So all questions will be based on rotator cuff. Do you have this? Do you have this? Do you have that? And then you find out that patients say, no, 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 no. And then you'll be like, okay, what next? Then you move into the other aspect again to see if it can also fit in with that pattern. So it's not only one thing you will base, like you basically put all your eggs in one crate that yes, it's definitely frozen shoulder. It's definitely polymyalgia. It might not be polymyalgia. It might be inflammatory arthritis. It might be infection just on a low key, like it's just starting to manifest. It might be anything because we're talking about if with the presentation, it's aches and stiffness. What could cause it? So the symptom pattern. Yes, the key question to ask, sudden or gradual? Was it present before 24 hours? Was it worse? Is it worse in the morning? Morning, do you get morning stiffness? If you get the stiffness, for how long does it last? Does it improve through the day? Does any activity specifically makes the pain go like improve the stiffness? Is there any hip, thigh, pelvic girdle symptoms? And you also ask about the function. What exactly is difficult for you to do? Is it using your like wearing your putting on your coat, making your hair, reaching out for something, chair, like navigating in and out of the chair, pushing yourself out? The stiffness, is it a true stiffness or like true is stiffness, and is it a painful stiffness, or the weakness, is it true weakness? Passive movement, is it possible for you to do actively and passive? So you all check with this ones. That way you will be able to narrow, like, this is what is happening to my patient. So you also screen, of course, because it's a sudden presentation. If you're thinking polymyalgia rheumatica in any patient, you're thinking polymyalgia, you definitely need to screen for giant cell arthritis, because that's the worst thing that can happen is like patient losing their visual. So definitely you will check. Do you have pain in the headaches, scalp tenderness, jaw or tongue claudication? Do you have any issue with your vision? Do you have any temporal tenderness? If no to all this, then you're sure. Reaffirm that yes, it is no to all this, and then you're sure giant cells is less likely. Okay, still polymyalgia can be there without giant cell being arthritis. So you go on to screen for systemic features. That's where you're thinking maybe infection. Yes, fever, sweats, weight loss, reduced appetite, fatigue, recent infection, unremitting night pain, any history of cancer. All this is another thing that can cause sudden onset of shoulder pain bilaterally. And then you can, of course, look into the neuro. If it's less likely bilateral, like at once and sudden. It can be gradual and then it get worse. But still, you have to just screen out for neuro involvement. Hand clumsiness in case of myelopathy, dropping things. Usually, we see the symptoms more in the hands. So we definitely need to screen for that. Paresthesia, weakness, any gait disturbance, falls, leg stiffness, bladder and bowel changes, gait pattern, all these are stuff that we need we screen out. And then the history also. Subjectively, is the patient diabetic, any thyroid diseases, any past or like previous history of polymyalgia rheumatica, because they can have a relapse. So any previous history of polymyalgia or giant cell arthritis or polymyalgia giant cell arthritis, any inflammatory arthritis, is a patient on statins. Like I said, long use of statin can cause these symptoms as well. So we need to also screen, make sure that it is not polymyalgia, it's more the statins. And then that can also be addressed through the GP. Recent vaccination, sometimes vaccination, if you've had recent vaccination, then that's injection that can, how was it given? Like, is it in the deltoid? Was it painful? All those history around the vaccination. Was it swollen? Was it red hot at the initial? Like, that will also help screen for any infection per vaccination. And what type of vaccination was the patient given? Steroid use, long-term steroid use, cardiovascular risk factors, of course, to screen for cardiac referral. So that's good. Thank you everyone for your contribution. Yes, we move to another one. Yeah, so though we do not anchor on a gym strain when the pattern suggests possible systemic diseases. Usually we will always think, yes, gym strain because he is a soldier, he goes to the gym. We are things to that will raise our concern is age 75, 74 for polymyalgia, anything 50 and above, then we can start thinking polymyalgia. Bilateral aches and neck stiffness. So it's not a unilateral presentation, it's bilateral presentation. That's one red flag again. We need to look into what is actually happening. No mechanism of injury, no trauma. So it's another reason for us to raise our suspicion that something sinister is going on. Rapid functional decline. Within 24 hours, he is not able to do overhead activity and he is not able to do his usual active stuffs. Definitely that is progressive. So we need to also put that into consideration. Difficulty dressing up, obviously, you've said that. Possible inflammatory pattern if morning stiffness is prolonged. So if at all he mentioned stiffness in the morning, but for how long? So we just need to know that, and then we can fit in the puzzle. Polymyalgia, giant cell arthritis must be screened before routine shoulder management. So if we are thinking that it is a strain to both shoulders, so we definitely need to screen out for systemic inflammatory before we are based on, yes, this is coming from the shoulder, like the shoulder, locally from the shoulder. So initial differential thinking obviously will be polymyalgia rheumatica, acute bilateral shoulder pathology, less likely, but it can be possible. Still, it can be possible. Cervical neurological pathology, medication-related myopathy, and infection, malignancy, or other serious systemic causes. So likely approach, we clarify the morning stiffness, hip, pelvic girdle symptoms. We screen urgently for giant cell arthritis. That's like very important in patients presenting with bilateral shoulder. It's very important. We wouldn't want to miss it as FCPs. Yeah, very, very important. Check systemic features and infection, malignancy clues, and of course, after screening, like if the patient say no, no, no to all this, patient denied this, you mentioned all the things that patient denied because you ask and patient denied. So you will not only say nil this, nil that. Patient denied symptom of visual pain, all those symptoms of giant cell arthritis, temporal tenderness, patient denied them, so you are free. Screen neuromyelopathy if weakness or gait features emerge, and communicate with the GP or the medical team in case of polymyalgia rheumatica, giant cell arthritis, or systemic pathology suspected, because obviously that's urgent, and you safety net clearly in case or you screen and everything is no, then you treat as MSK, but you have to safety net the patient that you've screened, there is a condition, bilateral shoulder pain could be as a result of polymyalgia, and this is what we see, this is the pattern. So if you see such and such and such, please, it's an urgent review by medical team, do come back. Or even if the patient got polymyalgia rheumatica, no giant cell arthritis, still you have to safety net for giant cell arthritis. In case that thing comes, like you see this and this, please, it's another emergency, just come back as soon as you can. So the key learning point is in an older adult with bilateral shoulder and neck stiffness, you first decide whether this is inflammatory, systemic, rather than local shoulder pathology. Thank you. So the key take-home message for today: shoulder pathway reasoning in primary care. Most shoulder pain is musculoskeletal, agree, most of them, but not all shoulder pain is safe for routine MSK care. So rotator cuff related shoulder pain sits on the spectrum from tendinopathy to traumatic tear. So when we are dealing with rotator cuff related pain, we've got to define which is it that we are dealing with. Is it a tendinopathy, a partial tear, subacromial impingement, full thickness tear? We need to make it clear which one we are dealing with. Painful weakness is not the same as a true objective weakness. So if you've got a weakness, you've got to assess properly. Is it a true weakness or is it a pain-inhibited weakness? A stiff shoulder is not automatically a frozen shoulder. So with stiffness, we need to check, it's not automatically a frozen shoulder. We need to check with the age, check with, sorry. Check with the range. Was there any history of trauma or is there any systemic features? Because that can also lead to stiffness. So we don't miss out on those things and we will be treating frozen shoulder instead. So bilateral shoulder stiffness in an adult should prompt PMR and giant cell screening. The hot, swollen, painful shoulder with systemic illness is septic arthritis unless it is proven otherwise. Progressive non-mechanical scapular pain with respiratory, neurological, or systemic features need urgent review. It might be a referred pain, either from the lungs, the heart, or other viscerals. So exertional shoulder arm pain with chest symptom, sweating, nausea, or breathlessness may be cardiac. Escalation is part of safe FCP practice. So that's the role of the FCP. Urgent escalation. Finally, we shouldn't force every shoulder presentation into a shoulder diagnosis. We shouldn't force it that it must be, no, it must be a tendon, it's just a rotator cuff tendinopathy related pain. We shouldn't force it. We should dig deeper. We should use clinical reasoning to identify the safest pathway. Thank you. And here we go. This is the references and any questions so we can treat the questions. So I'm just going to stop sharing so we can ask for any questions and then we treat question and answers in 20 minutes. We still got 20 minutes. Any question?
Please, I need more light about this. This, what do you call it? That osteoarthritis, what that we usually mention.
Sorry, can you say that again, please?
Something like that. Hello?
Yes.
This osteoarthritis I usually mention. What? Let me remember the term. Usually
Sorry, can you say that again?
mention
It's a bit cracky. I can't really get what you're trying to say. Sorry.
there's one terminology that I usually mention.
Can you type that and
What
then
is
I'll pick that up?
Hello.
Okay.
Maybe you can type your question
Yes.
on the chat box. Maybe your network is not.
Osteoarthritis, I can't even remember it. Let me try in these conditions.
There is this chart I'm seeing. So it says since it was under 24 hours, I suppose, that you may want to order for X-ray for minor tears. I think that was when I was asking what do you want to know about the soldier with bilateral shoulder pain. So you may want to order X-ray for minor tears. That's just something I just want to talk on. So if you're talking about tears, obviously that's soft tissue. X-ray is not going to show any tear. Can't see any tear on X-rays. And when we were discussing about the rotator cuff related pain, like the spectrum, we mentioned the gold standard diagnostic imaging is ultrasound. So if you're thinking anything that has to do with tendons, burses, impingement, the best thing to go is ultrasound, because X-ray is not going to show you if there is a tear in the tendons. It's not going to show any bursa inflamed. You get so X-ray is not indicated for tears. So if you're thinking more osteoarthritis, you want to screen out, rule in or rule out glenohumeral changes, acromioclavicular joint changes, then you go for X-ray. Or if you want to also rule in, rule out frozen shoulder in a bit older individuals, you're thinking, is it frozen shoulder or is it osteoarthritis causing the pain? So you will go out for X-ray. X-ray will be able to show if the glenohumeral joint is okay. That way you rule out osteoarthritis and rule in frozen shoulder, and so you treat as such. I hope the person gets that, the one that wrote on the chat. Order for X-ray for minor tear. How do you screen for giant cell arthritis? So for giant cell arthritis, also, you ask clinically, you ask if there is pain or like claudication in the jaw, in the tongue, if there's got pain, headaches, especially the temporal region, if there is tenderness in the scalp, if there is, sometimes you can even see the inflammation like around the temporal region. So that's all something that you will check with the patient. It's other thing. In case of, yes, I will agree. In case of polymyalgia rheumatica, request for ultrasound, yes. I think there is this EULA screening recommendation that said aside the bloods, one other thing to check with polymyalgia rheumatica is ultrasound, obviously. That can also help rule in, rule out polymyalgia rheumatica. So ultrasound, yeah, I agree with that. But again, clinically, how can you rule out adhesive capsulitis? So ruling out adhesive capsulitis, with adhesive capsulitis, obviously it is the capsule that is involved. So thickening of the capsule due to inflammation can happen just like that, idiopathic in nature, could be as a result of other comorbidities as well. So if you go for X-ray, you would see obviously where the restriction of movement in the shoulder, as per frozen shoulder, is in the glenohumeral joint. So if you have stiff glenohumeral joint, you might be thinking of two things, especially if the patient is aged. So you might be thinking, could it be osteoarthritis that is causing this, or could it be frozen shoulder? So if you go for X-ray, X-ray can come back normal glenohumeral joint, no osteophyte, normal acromioclavicular joint or mild changes to acromioclavicular joint, but then the glenohumeral joint is okay. That way you rule out osteoarthritis, and more likely it is frozen shoulder, which can be idiopathic anyway and affecting the capsule. Do you get? So that way you rule in adhesive capsulitis by ruling out osteoarthritis, and so you treat as such. And the best line of management is, yes, in most cases, injection, steroid injection, and then obviously exercises, and that's it. Any other thing? Any other question? I see you more with the chats. Dr. Idris, no question? How many times is steroid? I'm not sure what you're trying to, okay, injection to be given. How many times, how many times is steroid injection to be given? Based on what? What are you trying to treat? Are you treating the frozen shoulder? Are you treating tendinopathy? What are you trying to treat? So all I know is you can only give the injection every other 6 months, because some patients don't get off pain immediately. Yes, it might work for others and it might not work for, like, it's a 50-50. It's not a complete like guarantee that if you do the injection, it will work for you, like the patient. Obviously, that's something you will let the patient know before they even have the injection done. So yeah, it might work for you and it might not work for you. And if it works for you, frozen shoulder, or it can last for frozen shoulder, it might work for you, it might not work for you. It might set in like gradually, you get the relief gradually, and for some, it might be just as quick as that. So you can only get one, I suppose. If it doesn't work for you for frozen shoulder once, I don't think you can get another one. I'm not yet injection specialist. Hopefully by the end of the year, I would be one. But before then, I think based on my reading so far, frozen shoulder should be one. Unless in the case of tendinopathy, that's when you can get it every 6 months. Then you can have a repeat. But for frozen shoulder, one, and then manipulation follows. So because if it doesn't work for you the first time, the possibility that it will work again when you are given is less likely. Any other question? Thank you too for having me today. Dr. Idris, we have 9 minutes. Should we end it for today? And then, yes, hopefully the next session will be in 2 weeks, so we just round up as quickly as we can. Thank you too for listening. and for having me here today. Thank you. Is there a place for ultrasound in frozen shoulder? No. 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 Not for frozen shoulder. Not for frozen shoulder. For frozen shoulder, you can only use the X-ray, like I said, to reel in or out. And that's it. Thank you, everyone. Dr. Idris, am I okay to go? Thank you, everyone, for listening today. Thank you. Ultrasound therapy. So that's it. It's somehow controversial. I've not done more of reading regarding that ultrasound therapy. For obviously, it's help to relieve any adhesion, but how effective is ultrasound therapy? I can't say, to be honest, because I've not read much about that. But I don't know, some of my colleagues here, they use it. I don't know if anyone have used ultrasound therapy to treat frozen shoulder. How effective is it, please? Can someone tell us? This is a very good thing. We can all learn from it. Ultrasound therapy to help. So is there anyone that can share with us quickly if they've done ultrasound therapy for frozen shoulder and if it has worked, or if they've got any not like anything to share as per how effective the ultrasound is in managing frozen shoulder? Anyone? I think it's not only about me talking. We all are clinicians and we all have experience, wonderful experience that we can always share. Please, in any of my distance session, if anyone have something to share that will benefit all of us, please feel free to share. And then, yes, we will all benefit from each other as well.
Okay, excuse me. I think I have used ultrasound therapy to treat frozen shoulder. And of course, in combination with exercises.
Yeah.
Now, the patients actually record that they feel better.
Yeah.
I wouldn't know if it's the placebo effect or not, but they come and say, "Oh, I'm glad you used ultrasound therapy for me. It made me feel better. I needed to do it again." So I've used it. I think they say they like it. But now I have also not read any research.
So have you used it in more than one patient, or is it like one patient that reports?
No, I've used it in more than one patient. I've used it in more than one patient. Yes,
I think you should be putting some like you should be auditing such cases, and then like any special case like that, just have a bit of reading around it, what the research say, and how did you like a case study, just like a case study, and
yes,
then
I'll do that next time,
yes,
please. Thank
yeah.
you.
Maybe I don't know. Again, another thing that can help is acupuncture. Have someone tried acupuncture, and how effective is that also for frozen shoulder? Acupuncture? No one? So yeah, with acupuncture, no, ultrasound. Yeah, okay. Dr. Idris.
Okay, I only know of a patient who had acupuncture somewhere else. And of course, she didn't get better, so she had to come for physio. And I used ultrasound on her. So I didn't do the acupuncture for her since she's done it already, and she wasn't better. But she wasn't better, obviously. That's why she had to come back to me.
Okay, and then you use ultrasound and she felt better.
Yes.
Okay.
But of course, she's a very old patient. This particular one, she's 84. And I think she also had X-ray showed that she has cervical spondylosis also, and bilateral frozen shoulder, more on one, was on one shoulder.
So did you get to see the report of the X-ray or see the actual X-ray itself? Is it more of degenerative changes or no changes like it? So you're leaning more towards frozen shoulder because with her age, someone will suspect glenohumeral osteoarthritis.
Unfortunately, I didn't get to see the X-rays because I wasn't the one who ordered for it. She only told me, reported that the doctor said she had cervical spondylosis and that physiotherapy was going to help her. So I didn't see the X-rays.
Okay. Just I feel just a bit of my own opinion. Like when the GPs or when the doctors refer patient to us that patient have got this, we shouldn't just agree with them. We need to do our own findings as well. Yeah, try as much as we can not to put financial burden on the patient, but we should, if it's a cervical spondylosis, like we should confirm, not based on what the doctors have said to us. We should also do our own and then reaffirm that yes, it is cervical spondylosis. Because sometimes, you just can't tell. They are not MSK. Most of them are not like MSK, will I say, trained stuff. So definitely one or two things sometimes might just not fit in.
Yes, please. But because of our setting,
Yeah.
and this is an old woman who has lots of, as in multiple medical conditions, I
Mm.
really didn't want to put her through the burden of doing another X-ray
Yeah.
or something. So I went ahead, I treated cervical spondylosis, that strengthening of the, cervical region with cervical traction. By and large, she got better. So for me, that's what that's I think the most important. That's oriented care. Since she
Yeah.
felt better, I didn't push for that, to get an X-ray or to see the X-ray.
And again, please, we should be careful using traction on all the individuals. Again,
Yes, please. Yes, please. Thank you.
thank you so much for sharing. Thank you. Thank you, everyone. Dr. Idris, it seems you're not online somehow. So see you everyone in 2 weeks again, hopefully. Thank you. Thank you, thank you, thank you so much. And good night, everyone.
Hello, Nika. Hello, Nika. I want to party. It's not to party. Invite you, come back.